morning, everybody, and my sincere thanks to the organizing committee, the President, Dr. Rishikesh Thakre, and Dr. Sanjay Vadi, Secretary of the IAP Neocon chapter, and Dr. Rajesh Kumar, the local organizing secretary. Now, I'm glad Dr. Dirari spoke before me, because my talk is going to be quite complementary and maybe supplementary to his talk. I will deal more with non-technical part. And maybe telepathically, the background of our slides also matches, you might have noticed. But in the technical content, maybe there's one slide that will match, rest all are going to be different. Now, I would like to share with you my journey and my struggle with improvement. And the reason I want to share with you is so that you do not make the same mistakes which I made. And you have a jump start in your journey of improvement. I'm sure all of you are aware of this. Why do we need to improve healthcare? There's a huge amount of data, literature. WHO has given statistics to show us how many, events or how many adverse events are occurring because of our care which we give. How much cost it leads to, and how much more mortality or morbidity it leads to. And obviously, as expected, in the developing world, these kind of adverse events due to the care which we provide are maybe 20 times higher, and it costs more life and more suffering. And yet, we talk of improvement to a much lesser degree in developing world as compared to the developed world. The basic issue, as someone in the audience was trying to say, was that there has been an explosion of knowledge because the research has advanced very exponentially in the last 3 or 4 decades. So we know much more than we are actually able to provide to the patient or we are able to do. So the gap between what we know and what we do is already widening. And with the current pace of research, it is expected that it will widen even further. So the whole goal of improvement science or quality improvement is that we want to narrow this gap. We want to be able to provide everything which is proven by science to all possible population. So my journey begins with my early days in medical career. I was very lucky and fortunate to be trained in 2 of the most prestigious institutions of India. I went to AIMS for my undergraduation and post-graduation. Moved on to PGI Chandigarh for my DM. And I was fortunate to have stalwarts as role models. During undergraduation, I was exposed to people like Dr. J.S. Bajaj, Dr. Ahuja, Dr. Tandon. And during my MD, people like Dr. Mehban Singh. And during my DM, people like Professor Wen Bakku and Professor Anil Naram, teachers of teachers. So what I learned from all of them and from the institutional environment was a lot of discipline, hard work, and we were always trying to find faults and errors. This was a mistake, let's rectify it. And 24/7 we would be on alert. We were very proud, very happy that we are available as doctors 24/7, Sundays, holidays, etc. And we would try to keep everything under good control. And we were quite confident and proud of the outcome we were achieving. Of course, we did collect data because there was a tradition. We were taught that audits have to be done to improve. So we would collect data, analyze it retrospectively every month, every year, and then try to make changes to make improvements. So that was my early career. Now just before I proceed further, I want to just allow you to give your thought yourself. These are the common problems I've listed which we encounter day in, day out. And how do we actually tackle them? How do we do it? So bedside class for MD residents at 8 a.m. We find out of 70 students who were supposed to be there, only 5 are there. So what do? I call all 17 of them. The remaining 12, I shout at them, reprimand them, warn them, and often I would maybe say, okay, we'll stop all the teaching sessions for a few days. And then it goes on and on. The baby gets a calcium extravasation burn. So I go into the unit, ask the nurse, the resident, how did it happen? or they will give some explanation, and then you warn them, this should never occur again, and maybe sometimes they give written letters, etc. So this is a typical way, but maybe you can think how you would actually tackle how you would tackle it. So my first encounter with a different kind of world, which actually laid the seeds of quality improvement, happened when I went for a fellowship in neonatology to University of Calgary, Canada, in the year 2000. And I was attracted to somebody called a quality improvement nurse and a quality improvement committee. And as part of fellowship training, the fellows are supposed to be members of various administrative committees. So I chose to be member of this particular committee to see how it works. What I noticed, and many of you would have maybe have the same experience who have worked abroad, the atmosphere is very relaxed, unlike our units where everybody is running, there's a lot of tension. There's no visible strictness or discipline being enforced by anyone. Everyone is confident, happy, proud of their work. But yet, everything is in very good control. And babies come out very well, the clinical outcomes are good, patients are satisfied, families are satisfied, staff is satisfied. So that set me thinking, why is it different? What is the difference? Why we are having different kind of experience in the two places? And I'm sure again, all of you who have visited abroad, even for short periods, would think, maybe they have more resources, they have millions of dollars, we are always short of money, we are short of machines, we are short of people. They have to see, maybe 10 patients in a day, they can devote 45 minutes per patient. They can do good counseling, good work. I have to see 200 in the OPD, so I'm very busy. And then some people like to say, they have better attitude. We Indians don't have better attitude. And then often you would say, "Wahan system chalte hain, hamare system nahi chalta." But then we stop at that. We don't understand, we don't think, what is the system about? Why it works, why it doesn't work. So where do these faults really lie? So if you look at the composition of any organization, whether healthcare or any other organization, it basically consists of 4 elements. There are people, there are processes, there are control mechanisms, and then there is a structure. And typically when anything goes wrong, we have a tendency to blame either the structure, we say, we do not have enough of beds or enough of buildings or equipment, or we blame the people, that nurses don't work, residents don't work, class 4 doesn't work. However, scientific studies have revealed that only in 15% of cases the problem lies with people. In 85% of situations, the problem lies with the processes or the control mechanisms and often sometimes with the infrastructure. But we never focus on that. So the first lesson which I have learned, and I would like you to understand, is that we need to develop what is called as systems thinking in scientific terms. That means we don't try to blame people in the first go. Look at why this extra position occurred. What was the circumstances? Why the residents did not come for the class? And ask 5 whys as Dr. Dirari was trying to tell us, and try to look at the root cause. And often you will find it is not the people, it is the process or the system which is responsible. The same situation again. So MD resident did not come. So you ask them. They will say, "Oh, I was doing sampling." Why you were doing sampling? Because the sample has to reach the laboratory before 9 a.m. If I do not do now, it will never go. Why the night resident did not do sampling? Because there were many patients, many resuscitations. Night resident was busy. And so on and so forth. Or maybe the hostel mess doesn't offer breakfast before time. So they cannot have breakfast and come. So there could be several reasons if you try to do the root cause analysis. So the question arises, if the problem lies in the system most of often, how do we change the system? How do we improve it? So the first principle is that for any improvement, you have to make a change. Without change, there cannot be any improvement. Very common sense, no high-fi science in that. If you keep on doing the same thing in the same manner, the result is going to be the same. And whenever we make a change, we often have to take a risk. If you decide I will play safe, The umbo bag will be kept in the almirah locked because if I keep it out, it may get lost and then I will be blamed by audit people. As the HOD or as the in charge, you are responsible why it is lost. So it's safer to keep in the almirah. So if you have that philosophy, then obviously no improvement can take place. It is similar to your money. My friend Srinivas Murthy always tells me, if you keep money at home in almirah locked, maybe it is safe, but after 7-8 years it will have no value because the money goes down and down. You have to take a risk, go to bank maybe. If you don't want to take a higher risk, go to the equity market. So you take a higher risk, more the gains can be, but you can also lose. So you have to strike a balance and decide how much risk I am going to take. So in the initial part of my career, when we were trying to make changes, improvements, a lot of effort was made, as I compared with the Western setup. So we want to change something, a lot of energy will be required, call people, shout at them, stand there, do policing. And after one thing, then you want to improve another thing, so on and so forth. And after a few days, there are so many that you tend to forget what I did 10 days ago. Difficult to keep track, very difficult to sustain. And obviously you cannot be there 24/7, 365 days. And often it was difficult to prove that these changes what we were making were actually improvements. Because we were not really collecting so-called process data. So I may believe that I did this way and it has improved. Maybe after 2 months another consultant comes and thinks, so what is this? This is not the right way. Let me do differently. Because we were not really doing what is called a process mapping. We were standing there looking at things and taking instantaneous decisions. Okay, let's do this way and that way and things will improve. So a common change strategy which we even follow now, I would admit, and which commonly fails, is that you formulate so-called comprehensive protocol using evidence-based medicine. We feel very proud. We did all the systematic search and we have done a review. We make a protocol and present as a product. The compliance is now dependent on our vigilance and hard work. And monitoring and success or failure is dependent on if any patient has a problem, then I come to know, oh, this is not working. I started this 6 months ago. Why does that happen? This is a very common thing. So the efforts are repetitive down the road. My professor did that. Next professor came, did same. I come and do the same, and my junior comes. So we keep on doing same things again and again over the years, but things are not changing because we are not following a systematic way. So change is not doing simply something different. It is actually engineering. So those of you who may have engineering background or understand engineering, so you have to understand the process and make one change at a time to know whether it is going to make a difference or not. So you cannot randomly decide, let me change this and see how it works. And second common mistake which we did and often still do, when we want to improve things or make change, we make the things more complex. We say, let's add the checklist of 10 items because checklists have been shown to improve things. So let us introduce checklist, 10 items. Who will do this? Who has the time? And whether it will be compliant or not. So you have to keep it simple rather than make it more complex. Scientifically we know, as human beings, we are going to make errors. We cannot be totally error-free. And more the complex process, more under stress we are, the risk of making errors is going to increase. And in settings like emergency, intensive care, or a OPD of 200, 300 per day, the risk of making error of judgment is going to be huge. And this is again statistically proven that as you increase the number of elements in a process from 1 to 2 to 3 and so on, the probability of successfully performing that is going to be drastically coming down. So if you look at the checklist which our pilot follows in aviation, it never has more than 6 components. Whereas the aircraft is such a complex machinery of so many systems, but their checklist will never have more than 6 components. And the checklist which we tend to make in healthcare are often 20, 30 components, 2 pages, 3 pages. So this slide is the one which is common between what Dr. Tiwari showed and I'm showing. So basically we were trying to do a lot of informal improvements instead of systematic QI efforts. So high reliability strategies which have been shown to be successful are that apart from doing evidence-based reviews and making protocols, you need to make decision aids or reminders in the system. You need to develop a system in such a way that people will do the desired action by default rather than they have to think. There has to be system of redundancy, which means if one person misses, the next person automatically catches that. So there has to be responsibility and redundancy built into it. Some schedules and standardization of processes. Let's say putting simple thing like intravenous cannula in a baby. Look into your own unit, whether all the nurses and all doctors follow the same standard procedures for putting IV, or everyone has a different process. So if everyone has a different process, you cannot make improvements. You need to standardize that. So take advantage of the work habits or patterns of behavior that people have, and then so instead of focusing on trying to change people, change the system which will accommodate people's behavior. So lesson number 2 is change is must for improvement, but at the same time each change is not necessarily improvement. And this is again very well proven or said by Walter Deming, the guru of quality improvement, who showed that only 5% of changes are going to be improvement and 95% are not going to be improvement. So don't assume that whatever change we make will definitely result in improvement. So what were we missing all these years in our efforts? First was, I hinted already, that we were not really doing a formal scientific process mapping before we made the change. We were not doing the tests of change, the PDSA cycle. We were implementing the change later. And so by what I mean by test of change is you need to collect data of that change, that yes, I made this change and this thing actually improved or did not improve. And then, although we were doing a lot of teamwork, the teams were confined to doctors, nurses, maybe allied departments. We were not involving the other stakeholders in the process. Class 4 you heard about. The procurement person, the administrator, the finance person. So all of them have to be part of the thing. If I want that I should have hand drugs available on each bedside in my unit. So there are people involved who control finance, people involved who control the supplies. So without them, I cannot be ensuring that this is possible. So we need multidisciplinary teamwork and not only teamwork. So as part of this process, learning process, so we wanted to start collecting data which will be live, which would allow us to do this, change test cycles on an ongoing basis. And because nosocomial sepsis is the most common problem we face, so we started a surveillance program for nosocomial infections, utilizing standard definitions, and we did not create a new system. Within the same system, we made some minor changes so that we are able to get this data. So we involved the nurses as part of their routine duties to collect some additional data. And we started utilizing run charts so that live data is available to everyone to decide what is happening rather than review the infection data retrospectively at the end of the month. So my lesson number 3 was that we need to map our current processes before we make a change. But who will make this map of the current process? It has to be the people who are doing the process, who are part of the process, which means the frontline junior resident, the class 4, the nurses. I cannot sit in my office and create a process map and say this is how things must be happening. I can often do that and I often find this is wrong. People are actually doing something different than what I am imagining. So you need to involve the frontline team who are part of the process to know really what is actually happening before you make a change. Now the driving force for change, as I said, is the multidisciplinary team. And I'm sure all of you understand that team is not same as a committee. In our country, in our institution, we are fond of making committees and subcommittees. And we feel very happy a committee has been formed to decrease infections or do something. So team is where individuals are working together as a equal partner. So it may be class 4, nurse, procurement, doctor, nurse, but all are equal partners. So there cannot be any hierarchical system. The environment of the team has to be safe. All contradictory viewpoints have to be accepted. You have to see the life from the other side of the world. It cannot happen that I say this, so this has to be right. And all ideas have to be considered fairly, and often the best ideas will come from junior most people who are working on the front line. Now, while we were trying to do this, as they say, where there is a will, God always show the way. So suddenly we came across this lady, Dr. from IXth Health International, who came with the same idea what we were trying to do. And we said, okay, can we collaborate between different institutions? So we did this collaborative work between 5 institutions of India in trying to decrease the nosocomial sepsis. And this was a huge, huge learning for me. So although we have been talking about collaborations, data sharing for years and years, but we had not been able to really do it. So this was a real collaboration, but it definitely showed us that our pace of learning and improvement really exponentially accelerated in 2 years' time. So we learned from each other, each one was doing something better than the other, and we tried to follow what other people were doing. So it's always good to have multidisciplinary teams for success within your own institution. But if you can collaborate with other institutions, it will make it even easier and faster and more fun. Now, question arises, what actually do we mean by quality? And who defines quality? So I will not go into the technical part, but important to remember that quality is from the consumer's point of view. When I go to buy a TV, I decide what I want in the TV, and not Samsung or LG who decide. Samsung or LG take feedback from the public, and they modify their television accordingly so that it's available in the market. So I will buy the TV which suits my requirements. In medicine, traditionally we have followed doctor knows the best. So we decide what is good for the patient, for the family. So times have changed. We have realized it is the patient or the family for us who determines what they require. Of course, they may need some bit of education. And at home, who determines the quality? It is your spouse and not yourself or the children. So consumer is the king. Patient or patient's family is the boss, you have to listen to them. And at home, wife is your queen. The current problem in our country where there is a lot of public violence, public dissatisfaction, and doctors are also agitated why this is happening, they are working so hard. It's basically a discrepancy between what we believe is quality and what public believes is quality. We would ultimately have to go the other side and realize what families desire, what patients want, and provide that to be able to satisfy them. Now during this collaborative effort, we were able to do a lot of so-called PDSA cycles, Plan, Do, Study, Act cycles, on hand hygiene or aseptic non-touch technique, or anything that would decrease the nosocomial infection. And what we learned during this was basically what the Institute for Healthcare Quality Improvement, the IHI, which you heard about, has been teaching us, that when you start your quality improvement journey, you have to have a theory and prediction. Then you test it on a small scale under a variety of conditions. Maybe you test on 2 patients, maybe you test on 5 patients next, maybe you test on the night shift, maybe you test on the weekend shift, maybe you test into the holiday season, and so on and so forth. Until then, you make it part of the routine operation, and then spread to other locations. Typically what happens is we often have been jumping from theory to making it as a routine implementation rather than testing. One typical example, there are many which we can see, but one example from my own city which I always quote, and people who have seen Chandigarh would know. So Chandigarh has very wide, beautiful roads, one of the widest road networks. And now we have also rickshaws and cycles going on the same road. So to make it safer, the administration rightly thought, let us make side roads or slip roads as they call it, so that the rickshaws and cycle walas can go on that side, and the fast moving traffic is segregated. So in most of the sectors, the roads were created, slip roads were created, and it costed maybe 1 crore or maybe more. But practically when you go, it is not being used. It is being used for either parking or sometimes the vehicles actually go, and the rickshaw walas and cycle walas are driving on the main road. which means this implementation failed. So one could have actually tested it on a smaller scale and found out why people are doing this and what we can do to make the behavior of people change. So as part of these efforts, we were recognized also, and in PGI they started, to our surprise, they started hand hygiene awards where they were doing anonymous surveys of all wards and ICUs, look at the best hand hygiene practices. And because of maybe our efforts of PDSA cycles, our unit was recognized for the best hand hygiene practices for 2 consecutive years. However, not all changes led to improvement. We had our share of many failures. And as I hinted earlier, the quality guru said only 5% changes are going to be improvements, the rest are going to be illusions of progress. So don't get, emotionally attached to your change idea. Often it may happen. I have given this idea, it cannot fail. Don't assume. So 95% of time it is going to fail. So be ready for that. So pearl number 6, must test each change on a small scale before implementation. Because it's more cost effective. You may waste a lot of effort, money, and then realize, oh, it's failing, and then you have no face to show. Dr. Didari did hint about another key ingredient for quality improvement, leadership. So leadership has to be such that it will inspire people to have confidence in themselves. And not only that, somebody is driving this. People have to be part of the work. People have to own the improvement strategies, improvement changes, and leader has to be honest and forward-looking and receptive to all the ideas coming from below. So, $1 million question. Common refrain is, I know what has to be done. I know how infection can be prevented. I know how first hour breast milk feeding can be done. But people don't listen. Nurses nahi sunte, resident nahi sunte, or my colleagues don't do this. I do this. So, $1 million question, why people do not change? So if you ask people, do you want to change? Yes, we want our country to change, country to progress. But do you want to change? Very few people will raise hand. And do you want to lead the change? Everyone is going to run away. And they will give you a million of reasons why we don't want to change. So there is a very interesting medical study, actual scientific study, where a cardiologist told heart patients who had previous myocardial infarction that you have very high risk of dying if you do not make 2 changes in your life. Do exercise and stop smoking. Simple thing. No money involved. But only 1 in 7 people were able to make the change. Other 6 did not. Does it mean other 6 did not like their life? They did not want to live. But they also wanted to live, but couldn't make a change. So how can we expect them to make a change for a process in hospital which is not affecting their own life? So problem is not of will or attitude. So, we often say, attitude खराब है लोगों का, will नहीं. So that is wrong. It is the gap between what we want to do and what we are able to do. And this is corroborated by our own Newton's first law of motion and inertia. That if a body is at rest, it is going to stay at rest. If a body is in motion, it will stay in motion at same velocity, unless there is a imbalanced force which is going to do it. And for applying the force, there is an energy which is required. And if the system is very old, you have been doing same thing repeatedly for 30 years, it's going to be even more difficult to change. So change is not easy, certainly. Now moving towards my last bit, what I have learned actually is that healthcare improvement is very synonymous with self-improvement. So instead of trying to change people, what we need to do is change ourselves. So for improving healthcare, what do we need? So we said we need a smart aim, we need leadership, we need discipline, we need to control our egos. And my junior gave this suggestion, how do I accept that? So we need to control our egos, we need to respect self as well as others, and we need to collaborate. What do I need for self-improvement? Exactly the same things. I have to be leader for myself. I have to have a smart aim for my life. What do I want to improve? I have to let go of my ego. I have to be disciplined. I have to collaborate with my family members, my friends, to learn from each other and improve. So to my mind, they are exactly similar. Just touching upon a philosophical aspect. What is the purpose of our life? At least I'm sure the senior people have thought about it, if not the younger ones. So we want to get rid of our shortcomings, improve certain things in our life. And to my mind, the multiple birth, life, death cycles in Hindu philosophy, if you believe, are actually PDSA cycles. That in each birth, we want to achieve few things. We are born again to achieve different things. Because ultimately, if you achieve everything, you will not need to be born again. And so this is a continuous quality improvement process. We simply keep moving our goalposts in life also. And change is life. Similarly, for improvement in healthcare, we need to make changes. And the real improvement in one's life starts if we can recognize our mission, our smart aim. If you are drifting in your life, you do not know why I am here, what I want to do, certainly you will not improve. It could be any mission. You may want to say, I want to earn money. But unless you decide how much money, you cannot achieve that. The aim has to be smart. If you want to be healthy, how much healthy? You have to be able to measure that or say that, then only you can improve. So to my mind, the continuous quality improvement and PDSA cycles have been there since human beings have been there. It's nothing new, simply a new terminology. So remember, change is very slow. We have to have patience. Often we get impatient. I have told this 10 times to my residents, still they keep doing the same things. Look at yourself. I have been trying for 30 years to do regular walk every evening. I have been unable to do it. So does it mean I am bad? No. And those of you are familiar with the Darwin's theory of evolution. So it is a slow evolutionary process. Genetic mutations happen. So it takes tens and thousands of births or changes in life to effect even small changes based on what the body is encountering. So it is not going to be overnight. Actually, there is a scientific concept called immunity to change, where basically human beings would try to resist any change. It is actually self-protective and life-saving. So if you understand this concept, you will realize why we can't change and why others can't change. So problem is not in people's attitude. People are actually unable to do what they wish to do. So we need to somehow help them narrow down this wish-to gap. So this brings me to what we call as human factors in quality improvement. In industry, they have actually utilized this concept very well. So they apply information about human behavior, human abilities, limitations, and other characteristics whenever they design a tool or a machine or a system or a task. So when people make mobile phones or give different software, so they are actually looking at human behavior, what people will do. So that is why today even a 2-year-old can use a mobile or a computer. Otherwise it's such a complex machinery. So human factor is not just applying checklists and guidelines or thinking that what I do is the only model and everyone must do that. This is again actual science. If you look at the development of mind complexity, you will find that people, even though maybe 60, 70 years old, are at different stages of mind development. And you all realize this. Somebody has a different, ability to understand or act. Another person is different. And a younger person may have higher ability. So it's not, although with age we improve, but it's not really age dependent only. And this development happens like our physical development, but it's a lifelong process. And it happens in stages. So if you understand this, we will realize that our co-workers may be at different stages of mind development, different stages of mind complexity. And that's why that explains their different behavior. So human factors engineering is a very useful thing if you can utilize that in a QI effort. It basically uses a systems analysis approach and it considers person or a human being as a critical component of the total system. As one of the part of the system. It tries to determine what should I change in the system or what modification should I do so that it is able to meet the capabilities or the qualities of the human being rather than change the person because this is the way I made the machine or the system. So we have to remember that. And some common examples again, just to share. We have people who are doing MD or DM. We have people who are coming from general category, which means they are young, soon after MD or some period of years. And the people who are sponsored who may join after many years of service. So which means they have a different age. And often people will come from different medical colleges with different environment. They have different family background, different family environment, circumstances, different aptitudes. But what we expect as faculty or as leaders, everyone should give the same output. Everyone should perform the task exactly in the similar manner. What is the net result? The candidate is always in stress. The faculty is always in stress, trying to get the person do the thing the way we want. And the net result is performance actually comes down instead of improving. Similarly, when we give MD thesis, with the person who will do a beautiful thesis on randomized trial, etc., logistic regression of it, and another person who is not even able to do a descriptive study because their mind complexity, their background, culture, everything is different. So instead of trying to say that each one should do exactly same thing and give same output, we need to modify our expectations and try to get the results as per their capability. So another thing you must remember that all of you are good, honest and hardworking. But the corollary is not that all others are dishonest, bad and insincere. Often we say, we are hardworking, but people don't do it. Everyone is hardworking, everyone is sincere, everyone is honest. So there is something called actor-observer bias. So when we compare ourselves with other people, what happens? I know my feelings, my thoughts, and I analyze my actions based on that. But for the other person, I only see what the person is doing. Let's say you are driving on the road and you see a person jumps the red light. You say, see, this fellow jumped the red light. Must be a madman. Another day you jump the red light and then you say, I was getting late, I have to reach for a operation theatre, a patient is waiting, that's why I jumped the red light. So you have a ready explanation because you know why you did it, but you have no idea why the other person did it. Similarly, there is a self-serving bias. If I do something good, I achieve A grade, this is because I worked hard, I studied so much. Other person did not achieve A grade, but this person is not good. I never looked at maybe this person was ill, maybe his family circumstances did not allow the person to be. So there is always a bias when you analyze other people and yourself and try to compare. So put yourself in other people's place and other people in your place too. So to summarize, these are the 9 lessons which I have done. First of all, whenever there is a problem, a bad result, think of systems and not people. If you want to make improvement, you have to make some change, but each change is not going to result in improvement, remember that. Before you make a change, try to understand the existing process, because if you try to create a new process, it is going to be very difficult to sustain. So it's always good to tinker with the existing process, which you must understand through the frontline workers. And always have a multidisciplinary teamwork. Get the change ideas from people. Tell them you want this idea and it's not my idea. And consumer or the patient or the family is the one who is going to decide what is quality and not me or you. Each change must be tested on a small scale, then a bigger scale and so on before you actually implement it. And all people are good meaning. It is not their attitude which is the problem, it is their ability to implement or do what they actually wish to do. That is the issue. And all changes are going to be slow. They are not going to end with your career or maybe next person's career. So have patience. And like you, all others also want improvement. They are also good, they are honest and sincere and hardworking. So I would end by saying that if you really want to make quality improvement in healthcare, start with yourself. Thank you.